let's start by thinking about what pain really is, what it's about. And it's a mind-body experience. We've gotten fairly adept at dealing with the body part, the nociceptive part. And it turns out we're not even doing very well with that. But to think that we can fix a mind-body experience by just dealing with the body is unrealistic. And to deal with a mind process with only pharmacology is unrealistic. And to think that the mind and the body are somehow separate. I was talking to somebody at the conference who said, well, but that's perception. Well, where does perception come from? It comes from our mind. What happens in the mind? It's the neurophysiological responses of hormones and neurotransmitters and cells that talk to each other. So with that underpinning, we need to figure out how to impact a person's experience of pain. That's really what this is about, is the experience of pain and the response of the person's pain experience, which is known as suffering. So how do we impact suffering effectively that's the million-dollar question. Really, we're talking about modifying responsiveness on a stress basis. So I talked a lot about mindfulness practice. How do we notice our thoughts and direct them back, for example, to the breath as an object of meditation? And when I get drawn into these faulty thoughts, I mean, we have these narratives about pain. Our patients have narratives about pain. They're telling themselves story. My head's going to explode. My back is killing me. My feet are on fire. Well, none of that's true, you know. And we do get attached to that idea, and helping people separate from that attachment is really what every clinician can do. It's really talking to their patient and talking about what it is that what their perceptions are, you know, how their focus is drilled into a belief system, and then starting to loosen the ties to that belief. And it's really going to depend on the practitioner whether they have a particular skill set. I mean, there's cognitive behavioral therapeutic interventions, and there's dialectical behavioral therapy, and there's acceptance commitment therapy. I mean, these are all manualized therapies that have great evidence behind them of efficacy for pain reduction. And mindfulness practice as a body of evidence that I was able to talk about, really suggesting that immune system changes and cognition changes, and there are changes in different parts of the brain, the somatosensory cortex and the cingulate gyrus and the insula and the thalamus. So we can impact the neurophysiology of the pain experience in the brain by a variety of interventions. Now, besides the thought-related interventions, there's physical interventions. You know, people tend not to move, and we all know that lack of movement causes pain to be worse. So how do we introduce movement into the life of the patient? I mean, again, it's going to be different for different clinicians, but it's imperative to talk about movement level. And patients are frightened of movement. So I stress the difference between hurt and harm. It will not harm you to move, but it won't feel very good. So graduated exercise is something that has to be introduced into any pain patient's experience. And you know, with a supervisor, if possible, some sort of trainer or some sort of physical therapy expert. But the essence is really helping somebody sustain an active movement plan, and that should include, it could include yoga or Tai Chi or Qigong. I mean, things that are really known to stimulate circulation and stimulate immune system function and decrease stress and anxiety. I think nutrition is important to pay attention to for clinicians. There are inflammatory foods that probably make pain worse, and there are foods that probably decrease pain. And when we're talking about toxins, the first toxin to deal with is smoking. every clinician should instruct their patient to quit smoking if they smoke. And there's a high incidence of smoking in people with chronic pain, despite the fact that they have a whole lot less pain if they stop smoking. And there's data that says if they're on opioids, the opioids will work better if they're off nicotine. So nicotine tobacco is a big recommendation. When it comes to foods, omega-6 fatty acids are inflammatory, so we're talking about grain-fed things that turn into sugar, because sugar really is the source of a lot of inflammation. White flour and the metabolites of that, and alcohol is inflammatory. Let's give the one glass of red wine for cardiovascular health. Other than that, alcohol intake is going to cause inflammation and cause increase in pain. On the positive side, increasing water, so hydration, it makes sense. You just sort of flush the system out and hydrate the tissue and enhance kidney function, and help the liver with its detoxification process. And omega-3s balance omega-6s, so fish with omega-3s or fish oil supplements. There's nuts and seeds and certain vegetables, powerhouse vegetables, that seem to decrease pain as well. There's a variety of pretty easy interventions. I think it pays to talk about that. And you're not going to be able to talk about all that in one session, clearly. But to have that on an agenda and to at least explore, what are you eating? And do you smoke cigarettes? And how much are you moving? And really helping people see their way really incrementally into increasing their activity and decreasing toxins and increasing pain-enhancing foods. It's really all about having a better life. I think most physicians, most clinicians really want to help people have a better life.